Hi, I'm Patty Cason. I'm a family nurse practitioner with a specialty in sexual and reproductive health, and I'm going to be talking with you today about 10 tips for optimizing your patient's experience with their implant or their IUD. Here are my disclosures. These are our learning objectives. So, I'm going to count down from 10. First of all, visualize the cervix when you're faced with challenging anatomy. So start by choosing the right speculum, and when it comes to an IUD placement, that will be the shortest possible speculum you can get away with. If you need to have better visibility, use a wider, not a longer speculum if you can help it. Because a longer speculum will splint the cervix firmly into place, and the tenaculum, when it's placed on the cervix and you're putting traction on it, won't have enough descent. The uterus doesn't have enough descent to be able to straighten out the flexure. And that may make it very difficult for you to even be able to get in through the os. So go wider, not longer. And in addition to the thumb screw, if I show you here, there is this handle screw right here. So as you can see, if I open the handle screw, I get a lot more opening than I do if I just am opening with the thumb screw. Okay, so in addition to this, I can actually go all the way up like that, and that will not actually adversely affect my placement of an IUD. So if you're having difficulty being able to see the cervix once you've placed a speculum, perhaps if the person has a very large body habitus, some of the things you can do is to have the person come all the way down on the exam table as far as possible. That will allow maneuvering of the speculum once they're all the way fully down, and then have their hips all the way over the edge of the exam table, because that drops the pelvis and the cervix forward, and it allows the cervix to pop into view more easily. Having the person raise the buttocks either by putting their own fists under their buttocks, under their hips, or you could actually put a pillow there or a block, if you will. You could lower the head of the table. This is my personal favorite in terms of success. If nothing else works, I think this always has for me. And that is they just lift their knees up to their chest, like in a knee to chest position, and they hold their knees themselves. You could have a medical assistant help as well if that's important, but just having them lift their legs up will allow you to put the speculum in and have the cervix in position, and then they can put their legs back down to a comfortable position. If there's a lot of tissue in the vagina that's encroaching on your ability to see the cervix, you can put a condom over the speculum just like this. And let's talk about some instruments. This is number 9. We're in the countdown. And these all, if you can possibly have them on hand, will really help. So, os finder device. There's these that are disposable. And then there's these that come in many different, not many, but 5 or 6 different tips. So there's ones with very small tips, and there's ones with a very quickly tapered tip. So it depends on whether it's the external os that's pinpoint or whether the internal os is difficult to get through. But os finders are your best friend, and they are not a particularly challenging skill to learn how to use. If you know how to use a uterine sound, an os finder is less invasive than that. This is for extracting an IUD that does not have visible strings, and it's called an alligator forceps. You need to get a very, very thin one because you're going to be putting this into the cervical os, so you don't want a really, really fat one. The thin ones can be expensive. They're worth their weight in gold because all you need is one. You're not going to run into this very frequently, but they're also fragile, so take care with them. And this is a thread retriever. These have just recently become available again in the United States. The same company that distributes the Kaya diaphragm will have these for you. And you just put them into the uterus and twist, and it'll bring the thread right out down through the os, and then you can use you can just grasp the threads or strings as you normally would and pull the IUD out. So 8, we're counting down. We want to think about how we cut the strings. We want to cut them long and blunt. You'd like to use scissors that are sharp, long, and curved and have a blunt tip. Okay, because from a safety perspective, you want a blunt tip so you don't cut the vagina. You want them to be long so that you can get in there to maneuver around where the strings are, which is deep into the vault. You want curved, again, so that you'll be able to not hit the side of the vagina wall with the tip of the scissors. And you want to cut directly perpendicular to the length of the string. So not like this, because you would be creating a sharp tip, like a bayonet, that would stick out and bother the partner. So you want to cut straight across, and very importantly, sharp scissors, because if they're dull and you go in and you cut, or you think you're cutting, and then you just pull out the scissors, you'll bring the IUD right back out with you, because you will not have cut through. They're too dull. You will have just crimped them. This happens a lot, so take care. And you do want to leave a long 3 to 4 centimeters, enough string so that it wraps around the posterior lip of the cervix. Our next tip is to remove contraceptive implants with the fingers-only technique, or the Popout Technique. My friend Debbie Bamberger made a beautiful video of the Popout or fingers-only technique for removing contraceptive implants. It's on my website, which is up here at the top, envisionsrh.com. The video is only about 3.5 minutes, and she shows you over and over again how to do it, and it becomes really obvious and easy to learn. The next tip is obviously something all of us care a lot about, which is to keep pain to a minimum. So Verbicaine, that's anesthetic through talking. And I don't mean that we should be talking at the patient. We should be engaging the patient in conversation that's really stimulating and engaging for the person to continue, so you really keep them talking about something that's interesting to them. And when you are doing the speaking, use words that aren't scary, don't have a negative emotional connotation, are gentle, calm words. Keep our vocal tone calm, slow, not speaking quickly and not speaking much, I guess would be the best way to sum it up. Some people don't like when their patient uses a cell phone in the room with them, and I would say this is not about that. This is when you are going to be performing a procedure on somebody. You're not actually needing anything from them in terms of participation. They don't need to be listening to anything that they're learning about something, about their health or about contraception. They're really just trying to get through this experience. And this is a really wonderful way for them to help themselves get through the experience. You can also ask them, what has worked for you in the past when you had something that you were doing that was potentially uncomfortable or painful? Is there anything that's worked for you in the past? Perhaps the person does guided imagery or, mindful meditation. One clinician I know said that she asks her patients, it's all adolescents that she works with, and she asks her adolescent patients to not look at social media for several hours before they come in, so that while they're having their IUD put in, they can catch up on everything that they have been missing for the last few hours. NSAIDs may reduce placement pain, not reliably in every study, but certainly most of us do that. And they have been shown to help with post-placement cramping, which can sometimes be significant as well. There's one study looking at lidocaine prilocaine gel applied for 7 minutes, and it was statistically significantly less painful. We don't have that formulation available in the United States yet, and that really was a pilot study, so early days, but that might be something really wonderful. There's really interesting cocktails that you can use with benzodiazepines and opiates and acetaminophen. These are really for your patient that's highly anxious, has already consented before you have given them the cocktail, and obviously they would need somebody to drive them home. The best data, most recent data, and really the most effective thing we can do at this point is to offer somebody a cervical block. So if you're not accustomed to doing that, it would be a really nice skill to learn how to do and to be credentialed to be able to do in your site. And it's not hard to learn, and it's very helpful for that person who would like to do something to reduce the potential for them having pain and discomfort. We didn't know for a long time whether placing a cervical block was going to be equally painful to the procedure itself. Now we know it isn't. The cervical block doesn't hurt as much as the IUD placement. So we finally have 3 studies showing us that. When we're looking at use of a tenaculum, we want to think about not going too deep or too wide, only as deep or as wide as you need to avoid tearing through. Close the tenaculum very, very slowly. Or alternately, put 1 cc of local anesthetic right at the site where you're going to place the tenaculum. Or have the patient cough very hard right at the moment that you're going to place the tenaculum, and then you would do it quickly. So it's sort of one or the other. They haven't been shown to be one better than the other. If the person's going to have, if you're going to have them cough, put the tenaculum right up against their cervical os at the place where you're going to be placing it before you have them cough. And before you even do that, have them practice a cough, because otherwise they're probably going to be like, because they don't want to cough out their speculum, which is a really good point. So you want to also put your finger right here on the speculum just to hold it in place while the person coughs. The most important thing that I think we can do with procedures that I'm talking about today, implants and IUDs, is to move slowly. That is the most important thing you can do from a safety perspective, but it's also the most important thing you can do from a comfort and pain reduction perspective. So even if you're very experienced and you do these all the time, think about just slowing down every step that you do. Just do it more slowly. Instead of going in really quickly to get to the fundus, try going really slowly to get to the fundus. Just a few extra seconds is all that it really is. You could consider using a thinner diameter sound, like a 3 millimeter plastic sound, or occasionally you can find a 3 millimeter metal sound. Or an endometrial biopsy. The brand name is Pipel, but an endometrial sampler is the generic name. Most people don't know what an endometrial sampler is, so I have to use the brand name to let you know what we're talking about. And once you have, that's a thinner diameter also. So that's another way to sound more comfortably. Another thing with the sound is, especially in the beginning, people will go to the fundus and then want to check and make sure that they're in the right place. And every time you touch the fundus, it's uncomfortable for somebody. So be aware that you'd like to nicely, slowly, intentionally proceed to the fundus, touch the fundus, and then leave. Another thing you can think about is when the sound is, pretend that this is the cervix and this is the fundus. Okay, so this sound is all the way in, all the way up to the fundus, and now I want to be able to measure it. You can take a scopette, put it around right next to, I'm trying to get right in front of the camera, put it right next to, I'm moving this so you can see, right next to the sound, and then pull them out together, and then this allows you to read it more easily. If you can see that, you can hold the, sorry, there we go. You can see that it's holding it right next to it. Place implants atop the tricep, not between the triceps and the biceps. Initially, we were taught to place the etonogestrel implant in the groove between the biceps and the triceps. We are now advising people to do precisely the opposite and avoid that groove, because that groove is laying right at a plexus of nerves and where there are vessels that if you go deep with the implant, you can place the implant into the vessel or can disrupt the nerve plexus. So there have been migrations into the chest wall, and so this guidance has changed considerably. So now we do not do that, and now we put it atop the triceps, right there. Offer the most effective emergency contraceptive as first line. Is that ulipristal acetate? Is that levonorgestrel emergency contraceptive pills? Why, no, it is not. It is a copper IUD. The selected practice recommendations from CDC have very clear instructions about how to do it, and If you have not yet started to be able to place implants and IUDs on the day that the patient's asking for it, which may be the same day that they have come in for a visit for something else, if you're not yet able to do that at your site, this is actually a really nice way to start, because there's decrease in efficacy for the oral emergency contraceptive pills that people have available to them in the United States. There's decreased efficacy with increased weight. With the levonorgestrel emergency contraceptive pills, a BMI over 25 is already starting to see a great decrease in effectiveness, and over 30 probably is completely ineffective. And with ulipristal acetate, it's at a BMI over 30, it's starting to show less effectiveness, and over 35 probably not doing much at all. Add to that the fact that ulipristal acetate is an anti-progestin, and you'd need to wait 2 weeks after taking ulipristal acetate before your hormonal contraception can be relied upon. And you would wait 5 days after taking your ulipristal acetate before you would even start your hormonal contraceptive. So all of these are opportunities for another exposure to having a pregnancy that you don't want. So the copper IUD is almost 100% effective. It's definitely over 99%, and in many studies there just are no pregnancies. My personal most heartfelt favorite is please think about helping to make no barriers to removal of implants and removal of IUDs. Saying something to your patient like, this device is good for, and then depending on what it is, how many years, it's good for up to, let's say, 7 years. But if you want to get pregnant before that, or if you want it out for any reason, and this is very important to let somebody know, if they want it out for any reason, we'll remove it for you, and your ability to get pregnant goes back to whatever's normal for you immediately. But this needs to be true if you're going to say this to them. You need to be able to just allow anybody who has a device in their body to request removal without having to justify it. Because a lot of providers are really reluctant to remove devices. They're highly effective, they're very safe, and we think they're wonderful, so we want to encourage people to keep them. Unfortunately, that starts to cross the line into coercion too often, and so we'd really like to think about respecting somebody's autonomy, and if they want it out, it's out. Basically, you want it out, we take it out. It's nice to be able to offer to somebody management. So if somebody's having a concern and you've been able to say, can you tell me what's concerning to you about this? And they've expressed something that's concerning that you think you can help with, you can offer management, certainly. But it's not about negotiation, and it's not about trying to convince the person to keep their method. This is their body, and they have given up their reproductive potential to the healthcare system as long as we are in control of that device that's in their body. So I don't think that's what we really want to be doing, is controlling other people's reproduction. I think that's really up for them to do. So I know I'm sounding like I'm on a soapbox, but please, when you're discussing placement with somebody, even before you put the device into their body or somebody puts the device into their body, let them know it's their right to have it out anytime they want. And that if somebody starts to give them pushback or tries to convince them and they don't want to be convinced, then it's their right to have it removed. So there are wonderful management strategies for dealing with bleeding, and we talked about that in another webinar. And I encourage you to learn all about that and have that as a really good whole bevy of things in your toolkit for your patients, but only if that's something that they are open to. I heard a terrible story a couple weeks ago about a provider who sees patients coming in with very odd complaints about their IUD, and she finally figured out that what was happening was that there wasn't anybody in the community that was taking them out. So people who wanted to have a child and wanted their IUD removed to have a child realized they had to make up really extreme stories about what the medical problem was in order to have somebody feel like their concerns were justified enough to have the IUD removed, when in fact all they wanted was to have it removed so they could have another child. No more fainting. So a vasovagal response, also sometimes people call it a vasovagal episode, or it's, one of its nice formal names is non-cardiogenic syncope. So you know what happens. You end up passing out. So it starts though, it's a reflex. It's like a Babinski reflex or a knee-jerk reflex. It's doesn't make sense. And it starts with pooling of blood in the extremities. And then after that, it triggers both bradycardia, so a decrease in heart rate, and a drop in blood pressure at the same time. So as these things are happening, blood pressure and pulse coming down at the same time, the perfusion to the brain is not good and eventually gets so bad that the person has a syncopal episode. So this happens more likely if the person is dehydrated or hasn't eaten anything. It is associated with all kinds of pain, particularly cervical manipulation. If somebody's had previous episodes, they're more likely to have one, but in fact, anyone can have a vasovagal episode at any time. So the really good idea would be just to know how, if you start to feel this signs and symptoms of a prodrome, how to stop it before it continues. And that is something that you can do, and I'm going to encourage you to teach all of your patients how to do that for themselves. Signs and symptoms. We all know what they are. You get this horrible green hue of to your face, gray-green, look like you're dying or dead. Diaphoresis, feeling suddenly hot or suddenly cold. One that people don't often appreciate is a sudden need to go to the bathroom. If your patient says, is this going to take much longer? I really need to go to the bathroom. They may very well be starting to have a vagal. Yawning, dilation of the pupils. Anybody complaining of weakness, lightheadedness, you know what? Anything that they're complaining of feeling weird, you can assume that they're starting to have a vasovagal. So the way you can avert it is to clench the muscles, tense the muscles in the hands, the arms, and the feet and the legs, all of a sudden really tight, just as hard as you can, isometric. Hands, arms, feet, and legs, not the tummy, not the buttocks, not the chest, not the face. Extremities. You're grasping the muscles so that the pooling of blood in the extremities gets pushed back into the center of the body, and that'll abort the reflex just like that. So the person doesn't have to bring their legs together, they don't have to pump, just tense the muscles. I ask my patients to practice this. I tell them, this is my entire script. Many people have, like let's say they're going to have an IUD placed or get a shot. Many people who have an IUD placed get dizzy, and sometimes they pass out, they even faint. It doesn't mean there's something wrong with you if that happens, but it can be scary. So, if you feel nauseated or you feel dizzy, you know what, if you just feel weird in any way, tense the muscles in your hands and your arms and your feet and your legs really hard. Go ahead and do it now. Practice. And if you can do it at home right now, practice hands, arms, feet, and legs. Tense them as hard as you can. Hold them, hold them, hold them, hold them, hold them. And then when you think your patient's fatiguing, you can say, okay, go ahead and relax. If you start to feel weird in any way while we're doing this procedure, or while you're having your blood drawn, or while you're getting your shot, go ahead and do this and it'll stop it. Please teach all of your friends and all of your family members and all of your patients and all of the people you work with how to do this, and then maybe people will stop vagaling. So my final one, I told you that slow is important. My final tip for you is slow down. So when it comes to a sound, what does that mean? It means holding the sound like a dart or a pencil, if you will. Bend the part of the sound right over here, which is going to go into the uterus. If you're going to bend, don't bend out here. And if you're going to bend, just make a nice gentle bend with sterile gloves or through the packaging. Right over here. There we go. So you're going to put enough traction with the tenaculum to straighten the axis of the uterus. That's really going to help prevent perforation. And then you're only going to use finger or wrist action. You're just going to be making your sound go forward this way. Just wrist, just fingers. So I am not using my elbow and I am not using my shoulder. I would if I was throwing a ball, maybe. I'm not very good at throwing balls. So you could also elect to brace your finger on the edge of the speculum while you're sounding so that you're in this sort of a situation. So you're holding your finger like this. It just limits the amount of distance you can go. Or if you can think about holding it, if holding it like a dart isn't an analogy that works for you, think about holding it like a pencil. So you're just like that. Okay, and think about it, if it's a dart, you're sort of throwing, it's as if you would throw the dart on the wall, right? But you're going to do it slowly, and you're only doing it with your fingers and your wrist. So, and here's the slow tip, is you're going to gently hold the sound at the os and wait. So you're not going to just press harder if you can't get through initially. You're going to just go right up to where you think it should be, and you're going to wait, and usually it'll just yield and you can go through easily and slowly. Or you can hold the sound at various angles to try to see where the magic door is, like this, but you're going to stop at each place and give it a moment to allow the door to open. Because normally when we walk up to somebody's front door and we knock on it, we don't generally just bash the door down. We generally wait for it to answer, for somebody to come to the door and answer. Another option you could do is, rather than pushing harder, is to place a block, if you haven't already, and then dilate. You can use the os finders we talked about, or you can use one of these nice small dilators. They're not very fat. They're actually thinner than a 4mm sound by quite a bit, and each one is curved, so you'd use this side first and then that side, and this is not sounding. This is dilating a little bit so that you can then come back around with the sound afterwards. So, and this is what I want you to really remember, because you've probably not thought about this one before. When you go through the internal os, stop. So when you're practicing, if you're new to this, or if you've been doing it forever, practice a little bit first, because your motor memory will be go through and up to the fundus, all in one movement, right? Lots of momentum. So I'm suggesting you go through the os, wait for a beat, and then slowly and intentionally proceed to the fundus. And remember, you're only going to touch the fundus once, so then you're going to know exactly where you are, and you're going to come back out, and you're going to measure. So that stopping once you're through the internal os is a motor memory that I would encourage you to learn and to bring into your motor memory, because if you are only thinking about it, then when you're trying to engage in a conversation with the patient and remember where all your tools are, and your body's wanting to just go straight through, straight up to the fundus, you're not going to remember to take that beat. But that beat is much more comfortable for the patient, but it's also much less likely to perforate. And that's all the tips, but I have to tell you that we've been wondering for a while whether menstrual cups actually are associated with IUD expulsion, and sadly, now we have studies showing us that yes, in fact, use of menstrual cups is associated with dislodging an IUD. So if you can teach the person how to break the suction nicely, that's great, or they perhaps may want to think about a different way to deal with their menses. Thank you very much.